All right. Hi, everyone. Good morning and welcome to the 2021 Minority Health Conference hosted here at the University of Illinois, Chicago by the School of Public Health and the Urban Health Program. My name's Vishwa Dhulecia. I'm a first-year MHA student here at UIC, and I'm also the conference chair. So the ongoing theme of the Minority Health Conference has been advocacy for change by celebrating past successes and planning for the future. The past year has been unprecedented for healthcare on a global scale, and for that reason, we chose to highlight the effects of COVID-19 on the delivery of healthcare and healthcare research on minority and underserved communities for this particular conference. Now, before we dive into the conference, I want to take a minute to recognize and thank the students that spent the last 10 weeks planning for today. These individuals consist of MHA students, MPH students, public health undergrads, MSN, and AGMS students. And without them, this event would not have been possible. So now for a brief overview of our agenda, we're going to start off with some remarks from Dr. Nadine Peacock, Associate Dean of Diversity and Inclusion, and Dean Wayne Giles, Dean of the School of Public Health. They will be followed by our keynote speaker, Dr. Fernando De Mayo. Then we will have our panel consisting of Angela Ellison, Dr. Alejandra Valencia, Dr. Cheryl Rucker-Whitaker, and Dr. Vita Henderson. Then we'll take a short break and come back for abstract presentations. So at this point, I'll hand it off to Dr. Peacock.
Thank you, Vishwa. Can everyone hear me okay? Great. So we want to welcome all of you to the 12th Annual UIC School of Public Health Minority Health Conference. Our conference traces its lineage to North Carolina, where in 1977, members of the Minority Student Caucus at the UNC Gillen School of Public Health held their inaugural Minority Health Conference. The UNC conference has been held annually since that date, and this year celebrated its 42nd anniversary. The largest and longest running student-led health conference in the country, the UNC Minority Health Conference attracts more than 500 attendees each year. In 2001, the organizers began broadcasting the conference via webcast, which allowed hundreds of additional people to attend and also prompted student groups around the country to create satellite conferences at their own colleges and universities. So UIC's Minority Health Conference started this way in 2010, and since that time has been a partnership between the Student Organizing Committee and the UIC School of Public Health Office of Diversity and Inclusion, or ODI. So the goal of this free UIC conference, as Vishwa has alluded to, is to support and highlight innovative scholarship and interventions addressing health inequities that impact communities of color. Although the UIC conference is now considered a freestanding one rather than a satellite of the UNC conference, it continues to follow the tradition of adopting the UNC annual conference theme, which this year is Body and Soul, the Past, Present, and Future of Health Activism. I should mention that each year, ODI staff member Linda Casanova Pineda works with a team of students to organize this conference. So Linda's always in the background, not taking credit, but she's always very instrumental in this, and want to give her thanks for her years of service. This year, the organizing committee was led by MPH student Vishwa Dhulecia, who you've just met. And we're all looking forward to hearing more from the students, the panelists, and the presenters, and our keynote speaker. First, though, it's my pleasure to turn the microphone over to Dr. Wayne Giles, who is the Dean of the UIC School of Public Health, who will give you a few words of welcome. Dr. Giles?
Thank you, Dr. Peacock, and it's a pleasure to be here. And I also want to add my welcome and good morning to all of you. I'm really excited about today's conference. I also want to offer welcome from Chancellor Emeritus and Vice Chancellor for Health Affairs, Dr. Bob Barish as well, who also want to add their welcome today as well. I also, similar to Dr. Peacock, want to really thank the members of the planning committee who really did an amazing job putting together what I think will be a really exciting keynote, followed by a very dynamic panel. I'm really looking forward to hearing all that they've said and are planning to say as well. I think the COVID-19 pandemic has really illustrated the importance of community engagement and and advocacy. And so I think as we look to the past and think towards the future, thinking about the importance and value of advocacy is vitally important. I think we also need to think, as we're thinking about policy changes and other things that we think might need to occur in order to empower communities, that we also think not just about development and implementation of policies and advocacies, but how do we ensure that communities are advocating for the enforcement of those policies and procedures, and we want to hear communities' voice as part of that as well. I want to highlight a couple of things in the agenda today. First, as I mentioned, I think you're going to be in for a real treat with our keynote address today by Dr. Fernando de Mayo. Fernando was born in Argentina. He received his BA in sociology and economics from the University of Toronto, and his master's and PhD from the University of Essex. His research and teaching interests lie primarily in the area of medical sociology and social epidemiology as well, with looking at specifically issues around structural violence. One of the things I noted in his bio, he said his work is really guided by the concept of radical statistics. And when I think about radical statistics, I think about a couple of things. Number one, thinking about sort of how we can use data to describe what's going on, but also how can we change. But I also think about radical in terms of the square root radical, which is talking about sort of how do we get to the root. And so really thinking about sort of what are the root causes of the issues that we're going to be dealing with. So again, I'm really looking forward to hearing from Fernando's presentation as well. He is widely published as well. Publications in the American Journal of Public Health, Journal of American Medical Association, International Journal of Epi, New England Journal of Medicine. So a really, truly outstanding scholar as well. As was mentioned, his presentation will be followed by an exciting panel as well. So I'm looking for a really exciting morning and encourage really great dialogue with the presenter. So with that, I'll turn things over to Dr. de Mayo.
Thank you so much, Dean Giles. It's a pleasure to see you and to see this entire community. Good morning. It's wonderful to see former students in this mix, colleagues who I've worked with in this past year of COVID, and a remarkable set of people that you've assembled today. So I'm so honored to be with you today. So let's see, let me share my slides. And I hope these remarks will kind of stimulate some thinking around the real challenges we face in health equity work, right? Both in public health, in the social sciences, in the healthcare system, all of the sectors that work in this area. So my main role now is as Director of Research and Data Use at the American Medical Association. We have a relatively new Center for Health Equity that was started about 2 years ago under the leadership of Dr. Alita Maybank. And I still have a faculty appointment at DePaul where I teach about one class a year in our MPH program in social epidemiology. So the bulk of the work at the AMA is really geared around this vision, right, of providing physicians with the consciousness, tools, and resources to confront inequities, as well as embed and advance equity across all aspects of the healthcare system. And that's a tremendous task, right? It really calls for the integration of public health knowledge and public health skills and public health thinking, concepts and tools and data into the practice of medical care. And we've had such a division in this country in particular between medicine and public health that has really harmed populations. So in many ways, the center is an attempt to begin to bridge those divides, right? And nurture deeper and meaningful conversations between public health and medicine. And I know you're already a part of that. So in the talk today, though, I also want to come back to a fantastic friend and mentor and colleague, I think, to all of us in this group, Dr. Linda Ray Murray. A few years ago, when she was the president of the American Public Health Association, she delivered this fantastic speech. I think it's one of the best 10-minute clips you can find on YouTube. And I've thought about this part of her speech for a very long time now. I come back to it time and time again. And this is the challenge that she gives us. She said, we are not where we need to be, and it is critical that we understand why. Our response as a public health field has often been to retreat into ever more technical approaches, to believe that somehow data can protect us and that evidence-based interventions will improve the health of our nation. So we lie to our young, right? And there she's including all of our students. We lie to our young. We train them in technical skills when we know policy is not determined by p-values or by data, but by power and politics. And again, I really encourage you to find her talk on YouTube. It's a remarkable 10 minutes, a deep analysis of history, of the contradictions and challenges embedded within public health and the intersection between public health and medicine. And this particular problem, this fundamental problem that I think we should all take on as health equity researchers. How do we do this? How can we possibly reconcile, how we can address and overcome this challenge that Dr. Murray brings forward, right? So we have training in technical skills, p-values and data, but also be aware and mindful and capable of working, right, in a power structure through politics. And this is where the idea of radical statistics came up. And Dean Giles, I'd love a follow-up conversation with you at some point, because I think we understand it in similar ways. So for me, radical statistics is a really tradition that I first encountered as a graduate student in England. There's a small group of researchers who have banded together under this label as a school of thought for several decades now. The fundamental idea is that we can describe and challenge inequities, inequalities that are avoidable, unnecessary, and unfair through statistical and quantitative work. That we can be concerned with power and social structure, as well as p-values and data. That our work needs to be historical and politically engaged. And perhaps most fundamentally, that we can be objective, but not detached. Objective in the sense that if I run a model and you run a model, we'll come to the same conclusion, right? Assuming that we're running the model appropriately. But we're not detached from the work, right? It is not just abstract math. We all come to this work with a deep passion and desire to alleviate unnecessary human suffering. We're not detached from the data. The data are not just abstract math. They represent the suffering of people and communities. So there's a deep meaning to the work that always has a human connection. And for me, those are some of the basic elements of radical statistics. So in the talk today, I want to kind of go back and forth between Dr. Murray's concern and her challenge to us and this notion of radical statistics, hopefully finding a place for statistical quantitative work in public health that really meets the challenges of the day, whether it's COVID or the longstanding inequities that we have in all of the major killers in our society. A great example of radical statistics is Data for Black Lives, an organization that I would urge you to look at. They came to prominence here during the COVID pandemic, issuing a fantastic report on the invisibility of race ethnicity data. And I love their framing: data as protest, data as accountability, data as collective action. They hold online seminars periodically and fantastic resources and a great network of people that you might want to connect with. And similar ideas show up in some of our best books in public health and social epidemiology. From Unhealthy Societies, The Afflictions of Inequality by Richard Wilkinson, which was really the book that started my career. I kind of stumbled across the book. I had just finished my BA and I wasn't quite sure what my career would look like. But thankfully I stumbled across this book and it really ignited a passion and a vision for what research can do and what research can focus on. Wilkinson and the whole realm of researchers around him laid out a simple but elegant hypothesis, linking area level income inequality to the health of populations. And it's been studied and debated and extended ever since. This work obviously also shows up in the work of Nancy Krieger, right? Epidemiology and People's Health, I hope is on all of your bookshelves. And if not, I would recommend it. Or David Angel's book, which is not statistical by any means, but still grounded in the same fundamental ideas of structural violence. right? And the fundamental idea that we can do work, we can do analyses, but the real challenge is to move from data to action, right? And make a real change in the world. The other key inspiration that I've drawn on for really throughout my career, and that really has guided my research and publications ever since reading it, is Paul Farmer, another fantastic author that I would recommend if you're not familiar with his work. He's published a lot. I think this is his best book, Infections and Inequalities, from 1999. In it and in other writings, I think he does more than just about anybody else to really refine the concept of structural violence, which originally originated in the 1960s with the work of Johann Galtung, but Farmer kind of put a particular vision on it, which I think is very, very powerful. It refers to social arrangements that put individuals and populations in harm's way. The arrangements are structural because they are embedded in the political and economic organization of our social world, and they are violent because they cause injury to people. And that violence is infant mortality, it's premature heart disease, it's COVID, right? And it's the political and structural and economic arrangements that expose our populations to that harm, to that risk. In terms of methodology, Farmer calls for a very simple framework that we've tried to live up to in many ways, calling for geographically broad and historically deep analysis, right? That to understand the health needs and the health challenges of any population, we need to understand the deep history of that population, and we need to understand that population in context, in comparison to others. And really, it all comes down to this. All of our phrasing, whether it's race relations, race chasms, there's a wonderful quote from Ta-Nehisi Coates, racial justice, racial profiling, white privilege, even white supremacy, serves to obscure that racism is a visceral experience, that it dislodges brains, blocks airways, rips muscles, extracts organs, cracks bones, and breaks teeth. You must never look away from this. You must always remember that the sociology, the history, the economics, the graphs, the charts, the regressions all land with great violence upon the body. And that's it, right? Like all of the scatter plots that I'm going to show you now, all the regression models that we've produced, me and my colleagues over time, they really come down to this, right? It's how this violence lands upon the human body as expressed through population health indicators. It is never just abstract math. All right, so if I could, I want to walk you through two book projects that I've had the pleasure of working on with really some fantastic colleagues. This one is called Unequal Cities, Structural Racism and the Death Cap in America's Largest Cities, that I've co-edited with Maureen Benjamins at the Sinai Urban Health Institute. Julie Morita, our former commissioner of CDPH, kindly wrote the foreword. And it really is the work of a remarkable team. I think there's about 30 collaborators and team members on this project. So it's certainly not just a solo effort. But in this book, which is coming out in September with Johns Hopkins University Press, we took on the challenge of extending some of the work that the Sinai Urban Health Institute has been doing for a long time, comparing inequities in mortality rates across US cities. And here we kind of took a comprehensive, systematic look across the board. Summary measures like life expectancy, premature mortality, and years of life lost, cause-specific mortality from the top 10 leading causes of death, plus homicide, opioids, and HIV related, given the significant and devastating inequities that show up in those indicators. I want to walk you through a little bit of the data, and again, just to stimulate some of our thinking and recognizing that all of this is before COVID. Right? COVID is adding a significant and horrible new burden on top of a devastatingly unequal playing field. So across the United States, in this time period of 2013, 2017, the time period that we covered in the book, we have an overall life expectancy of 78.6. The important thing to recognize is to begin to understand the variability that exists across our cities. Rarely acknowledged, because rarely have we looked at city level comparisons in this way. But the truth is that there's a 10-year gap just on overall levels of life expectancy across major US cities, from San Francisco and San Jose, the better off cities in this analysis, to Baltimore with Detroit and Memphis, not far behind. A 10-year gap. But that, of course, becomes even more important and and urgent when we start to disaggregate data. So this is the life expectancy differentials by race, still keeping the same cities. And we start to see the gaps, right, in life expectancy among white populations from 70.2 years in Houston to 78.7 years in New York City, and even larger gaps among Black populations in our cities, from a gap from 74.9 to 85.5. Across the United States, this amounts to a gap in life expectancy of 4.1 years. But the important thing to recognize is that this gap is also variable across our cities. So Washington right now has the largest gap of 12.1 years between the life expectancy of Black and white people. Whereas El Paso, a city with a relatively small African-American population, has a slight Black advantage in life expectancy. This is profound, right? We often frame health inequities as a deeply entrenched problem. It is. We also frame it as a monolithic problem. It is not, right? It varies. And understanding that variability for us is a fundamental challenge. If we can understand that variability, both across place and over time, we can get a better handle on the local policies that have made a difference, that have benefited and helped populations, and the other ones that have directly harmed. Right? We'll have a way of measuring and alleviating structural violence. Another way of looking at this is through all-cause mortality rates. So this 3-year average between 2016 and 2018, which is a paper that we published in JAMA Network Open just a few months ago, 759 across the board. We have our set of worse off cities with drastically higher levels of mortality. And we have our better off cities with drastically lower levels of mortality. And again, COVID is going to add a hit to this, and it won't be monolithic. It won't be the same across the board. Some cities will be harder hit, and some communities within those cities will be harder hit. We've seen that already with the Chicago data. Getting a handle on the data, though, brings out the possibility of looking at changes over time as well. So across the board, we have significant changes, some significant changes in city level mortality rates at an overall level. The bars in blue represent cities that have experienced overall declines in mortality rates. And the cities in orange are the cities that have experienced increases in mortality over this 10-year period. And again, always look for the inequities. Across the board, across the United States, the Black-white rate ratio is 1.24. Right? The Black rate is 24% higher than the white rate. But again, the variability is profound. The rate ratio is dramatically higher in cities like Washington, D.C. than it is in El Paso or Jacksonville or even Boston, which stood out to many of us as a surprise. And these two change over time. There are significant changes in the all-cause mortality rate ratios, right? A marker of the inequities between Black and white populations in our cities in terms of how long they will be expected to live. And here, Chicago is in the worst part, right? We're one of 5 or 6 significantly increasing cities with a widening gap in our rate ratios for mortality. And we've seen that in reports from CDPH as well. It should be ringing alarm bells all across our institutions that we have declining life expectancy for all groups in the city of Chicago, except for non-Hispanic whites. And again, before COVID is adding a huge new burden on a very unequal playing field. All of this culminates in annual excess deaths, which Maureen Benjamins and the team at Sinai has been championing as a key public health metric for a very long time. Here, Chicago fares worst of all. We have a very high level of inequity, a large gap between Blacks and whites, and a very large African-American population, amounting to a very large estimated number of Black deaths that happen every year, right? Because the Black rate is higher than the white rate. And of course, this is just the tip of the iceberg. This is so far a very Black-white analysis. All variability and intersectionality has to be accounted for. So this is the tip of the iceberg, and we're starting to get a better and better sense, a fine-grained sense of the inequities that exist across our major US cities. You might be wondering if there are any variables or anything that we have that helps us to understand or predict the patterns that I'm showing you. And there are some. First, with a word of caution, of course. So there's no one easy answer, right? There's no one variable that we could ever identify in a regression model or a statistical model that says this will be the answer. Not even universal healthcare would do that. But we have a range of characteristics of our cities that are showing some predictive capacity. First, it's important to recognize the variability that exists across US cities. They're not all monolithic. We can see that in the poverty rates, right? From an average of 21%, but a range from 12 to 39. Tremendous variability. The same with household income, an average of 50,000, but the range is 26,000 to 81,000. Same with percentage with a high school diploma. Our cities also vary widely in terms of racial segregation. And in the book, we explore basic measures like the composition of the population, more advanced measures like the index of concentration of the extremes and the index of isolation. In terms of percentage non-Hispanic Black population, we have huge variability across these cities, from a low of 3 in El Paso to a high of 81 in Detroit. And the same with income inequality. One of the measures that we've used is the Gini coefficient, which is a popular measure in economics and other fields to measure inequality in the distribution of income. There, the range is from 0.46 to 0.55, very substantial. Even our low, even our minimum is relatively high in terms of international comparisons. So even the most equal US city is still relatively unequal in terms of international comparisons. A couple of thoughts in terms of how these variables are interrelated with one another. Just a couple scatter plots to get us thinking about patterns that we have in some of the data. So in this scatter plot along the x-axis, you have the index of concentrations of the extremes for income. A measure originally developed by Doug Massey, popularized in recent years by Nancy Krieger and others. Low values, negative values, indicate the concentration of poverty, and positive values closer to 1 indicate the concentration of affluence. And as expected, this is not new science. This is not a new result that we haven't seen before. The hypothesis is very well supported that there's a steep association, right, between the concentration of poverty and affluence in any given city and its total all-cause mortality rate. But it's important to pause and reflect on that, right? It's almost such a commonplace finding that we take it for granted. But that is an injustice, right? That our capacity to live long and healthy lives is so deeply structured by the economic circumstances of the place in which we live. What we're adding now is that same measure, that index of concentrations of the extremes for income, which again measures the concentration of poverty and affluence in any given place, is also predictive of inequities in mortality rates. So the y-axis in this case is the rate difference between Blacks and whites in our all-cause mortality rate. And here there's the dual nature of inequality, that inequities and inequalities in exposures, in our structures, in our income, are manifest in inequities in our mortality and our population health. There's a bidirectional nature to this. Both variables will affect one another, and there might be that third variables also predict both, right? There's a deep theoretical framework underpinning this that recognizes that income doesn't just appear out of nowhere. Income is itself a consequence of further upstream systems of power, right? Our very nature of capitalism is at the root. So that's a little bit of a sense of the comparative work that we've been doing, primarily with the Science Urban Health Institute. I want to shift a little bit to a second book project that I had a few years ago with some fantastic colleagues, Raj Shah, John Mazzeo, and David Ansel. And here's the historical part. I remember Paul Farmer introduced the geographically broad and historically deep analysis. Unequal Cities is our attempt at the comparison of the geographic broadness, and Community Health Equity Chicago Reader is our attempt at the historical depth. So here we took the challenge of seeing what has this field looked like in the city of Chicago? How far back can we go finding and recognizing health equity work? And we went back to 1901. 1901 was the first map that we found, this one on the left, in this case, showing excess child mortality. This is a profound map, even before we had the community areas officially designated by the University of Chicago in the 1920s. We had maps showing the geographic concentration of poor health and other what we now call social determinants of health by area. So the map, in a very rough way, in a hand-drawn way, plotted the concentration of child mortality and overcrowding. We still do that. Foreign population, lack of sanitation, criminality. It plotted ignorance, which I've always found really interesting. I haven't seen any updated maps of ignorance. I don't know if people still do that anymore. Might be interesting to try. I don't know how they would do that. And economic distress, which of course we are still profoundly interested by. By the 1930s, we had far better maps, right? We had the community areas designated. We had the capacity to do the work of this kind. So the maps keep getting better over time, but I'll argue that the fundamental problem hasn't changed. The fundamental problem being the inequities between areas and between communities. Very important to recognize that in Chicago and in other cities, there's an amazing history of activism that I encourage all of us to read about and be connected with in however ways we feel comfortable. So we found and appreciated and republished a letter from Quentin Young on behalf of the Medical Community for Human Rights, using health statistics, in that case, using statistics on hospital births and deaths to challenge segregation in our health system. In the 1950s, we found this fantastic pamphlet called What Color Are Your Germs? Probably one of the most powerful pieces of writing that I've ever encountered, written on behalf of the Medical Committee to End Racial Discrimination or Racial Segregation in Chicago medical institutions. Again, living up to this promise of radical statistics, of not just describing the world, but changing it, using data on segregation and inequities to call for social change amongst institutions. And in the book, like others have done as well, we've documented the profoundly important work of the Black Panthers, who not only ran community health clinics in North Lawndale in the 1960s, but ran a very important sickle cell screening program when the city refused to do so. Our history is also one of ongoing struggle, right? Protests and social movements calling for a more equitable system. And we have this in Chicago, and we have this in other cities, and we are all connected to this network, and we support it in different ways. So in the photo that I just showed you was a protest calling for the reopening of an adult trauma center at the University of Chicago to serve the needs of the South Side. And in the book, I want to come back to the book one more time. We have these two maps. The one on the left, I bet you have seen. It was profoundly important, published in the American Journal of Public Health in 2013 by Marie Crandall et al. Really popularized the idea of trauma deserts. Did an amazing analysis looking at the location of our trauma centers, where gun violence was taking place, and documented the real harm that was occurring in our city by the nature of the setup of our hospital systems. It mirrored, for me, this map on the right side, which came from the 1950s in the What Color Are Your Germs map. And it's a very hand-drawn map, and it plots the ambulance route that took place from the South Side community of Alcott Gardens, bypassing 28 hospitals en route to Cook County hospitals, right? And that was the journey that a Black person would take because the hospitals would not accept them. Again, the story has remained the same, right? Of deeply unequal acts of structural violence embedded within the nature of our health system that harms populations. The maps are getting better and more sophisticated over time, but the fundamental problem hasn't gotten better. In the book and throughout our work and throughout your work, I'm sure, there's also conflicting narratives that you will come across. There's a deep history of blaming, pathologizing communities for poor health, right? Marginalizing and victim blaming. This was, for example, a well-intentioned but hugely problematic public health campaign. I am an outbreak beside an African-American baby. I saw this billboard. I took the photograph on Ashland Avenue, driving one day from DePaul to Rush. I pulled on the side of the road and I took a photograph, and was really struck by the graffiti, right? Can you imagine the anguish, the pain that someone felt seeing that advertisement and taking it upon themselves to get a can of spray paint to write beautiful on top? right? Countering the narrative, pushing back against the narrative that was pathologizing and blaming communities. So again, this is the fundamental problem. Does this map, which is fairly recent data from 2014-15, looking at infant mortality by community area, is this map really fundamentally different than the infant mortality maps that we had in the 1930s? Yes, every community is better off. We've experienced improvements in infant mortality, overall increases in life expectancy across the board. Every community is better off than they were in the 1930s in terms of these indicators. But the fundamental problem hasn't changed. The inequities between areas, the avoidable, unnecessary, and unjust differences persist. So how do we evaluate this? Is this progress? Every community is better off, but these relative inequities persist and in some cases have grown over time. These are some of the questions that really drive my thinking throughout my career. So this is a quote that I always like to share from Quentin Young, Dr. Quentin Young. He said that our patients represent the crystallized oppressions of our society as expressed in illness. What we are seeing are the most oppressed of our society, the most vulnerable, those least equipped by education, by birth, by economic resources, to resist the numerous oppressions of our society, from the air we breathe to the nasty housing that the poor are condemned to, and it ends up in all variety of diseases. He said that the conclusion you draw from that analysis is that you're dealing with a total societal failure. And working with the health question, you can begin that transformation that will make us more civilized than we are. I've always appreciated that quote and that framing of this issue, right, as a total societal failure. This is not about the biology and behaviors of individuals. It is not about psychological attitudes. This is a total societal failure, an act of structural violence that benefits some and harms others. So to begin to close, I want to just walk through one more example just to show you that something else could be something else is possible. Health equity is possible. And to do this, I want to go back to one of my home cities of Toronto. I grew up in Toronto. I was born in Argentina and moved to Toronto when I was 8. And I've always wanted to look at some Canadian data, really as a counterpoint. This is very much an apples and oranges comparison. And that was the point. We followed the strategy that some research methodologists call the most different research design, where you try to look at an association of a relationship that seems monolithic, that seems deeply entrenched, and you try to find a place that shows you that it's very, very different. So on this, we published 2 papers in Critical Public Health and Ethnicity and Health, really comparing segregation patterns and low birth weight. And we've had the great opportunity to work with Angela Ellison, who's on the following panel, and Representative Mary Flowers, and many others to try to include this research and advance the cause through public policy. So this is our starting point, the Chicago map of low birth weight. Not a disease in and of itself, but a very sensitive indicator of population health. First, recognize the tremendous variability across the communities. And again, this map mirrors diabetes, it mirrors asthma, it mirrors life expectancy. All the maps, at the end of the day, look very similar. They're all deeply correlated with one another. Our best off communities have a low birth weight prevalence of 3.5, as good as anywhere else in the world. The highest rate is about almost 20%. Profound differences just a few miles away from one another. And what we did is we took that scale from 3.5 to 20 and applied it to the 140 neighborhoods in the city of Toronto. Again, apples and oranges, and that was partly the point. And this is what the Toronto data looked like. We took that same scale, applied it to the map of Toronto, and it produces a beautiful map, right? It's not equal, it's not exactly equal, it's not perfect. There are pockets of difference, some communities doing better, some doing worse. But by and large, that's what health equity would look like. Their best off communities, their most advantaged, are the same as the Chicago communities with a low birth weight prevalence of about 3.5. Again, as good as anywhere else in the world. It turns out that their worst off communities are on par with our average communities. They've effectively chopped off the bottom half of the low birth weight distribution in a profound and important way. Just to give you a glimpse of what the data look like, This is the Chicago data in red. The red dots represent the Chicago communities. We have a line of best fit. The black triangles represent the Toronto communities. Along the x-axis, you have the percentage minority or minoritized population, essentially the non-white population in each community area. A steep association in Chicago, but look what's happening in the Toronto data. To be sure, there are lots of deeply segregated communities in the city of Toronto. There's problems with poverty, there's problems with inequality, but the most segregated communities, the least non-white communities, the least white communities have the same low birth weight prevalence as the majority white communities. Right? They have broken that association. The structural factors, again, this is not about biology or genes, though some critics of the paper have said, well, the biology will be different, the genes will be different, the demography is different. It is not, right? What we're seeing here are the effects of different public policies, right? Whether it's the healthcare system, better access to prenatal care, better public transportation, better welfare system, or, as we argue in these papers, a qualitatively different level of racism that people are exposed to throughout the life course. Right? For us, this is the toll of both interpersonal, systemic, and structural racism on the health of people. If you're interested, we've extended that work to other cities, but with a hypothesis of like, is Toronto as good as it gets and Chicago is as bad as it gets? The Boston data line up pretty similarly to the Chicago data, with no particular community as worse off as some of the Chicago data points. Oh, sorry, I thought I had a Boston graph as well, but I think I've missed it. Baltimore. Baltimore shows very, very close alignment with the Chicago data. Okay, so I've shown you a lot of data points, and I want to come back to Steve Whitman in my close, because all of this is not just about data. Right? Invoking that spirit of radical statistics, this isn't just about describing the world, it's about changing it. And it's about recognizing that all of the public health work that we do, all of the social epidemiology really reflects people. So Steve said, it's one thing to talk about data, but I think maybe it's possible to get lost in the data. So remember this is literally a matter of life and death. And we have seen that in this past year of COVID. We have seen a huge and tremendous and horrible toll borne predominantly by marginalized, minoritized populations. We have seen the blunt effects of structural violence. We have seen a diminishing of life expectancy across the United States. And once the data comes for Chicago, I bet we'll see it here as well. So our collective challenge is really to live up to Dr. Murray's call, right, that I started this presentation with, to recognize that changing this world is not just about more data and more analysis and more p-values, but it's radically reframing the questions that we ask, using data, using evidence, in the pursuit of health equity in collaboration with others. So I think I'll stop there, and I think we might have time for some questions or debate.
Yeah, absolutely. Thank you, Dr. DeMaio.
Sure.
We do have time for questions, so if you have a question, you can go ahead and raise your hand or put it in the chat, whatever you feel comfortable with.
Great.
I can ask a quick question if that's okay.
Yeah, please.
It's a wonderful presentation. I like it, really. Thank you
you
very much. So what do you see the fundamental difference between Toronto and Chicago in terms of healthcare providers? Obviously, that one is a public, one is a private. So other than that, anything else you have seen?
Yeah, there's lots of differences. To be sure, Toronto and Canada is not utopian society, right? They have the same contradictions that we have as a capitalist society. There's profit all over the Canadian healthcare system. The fundamental difference, though, is that the patient doesn't pay the bill at the point of service. There's a profound recognition of healthcare as a human right that I think does have a big effect. And we see that with other indicators as well, not just low birth weight. But I think it's more than just the healthcare system, right? It's recognizing the structural and social relations that really harm our populations, the deep exposure to inequality and racism and discrimination that affects the health of people. So I've always been really drawn to the work of David and Collins, who did this amazing study looking at low birth weight between US born white women, US born Black women, and immigrant Black women, looking at changes over time and the exposure of living in the United States as an exposure to racism and the effects of weathering. There's very much a connection to that work. Again, not that racism doesn't exist in Canada, it does. There's lots of documentation, lived experience to emphasize that. And I want to make sure I don't come across as saying it doesn't exist. But here it's qualitatively different and embedded in the makeup of our institutions and our public policies, and it affects our populations. Thank you for the question.
Thanks.
Yeah,
I have a question or comment as well.
great.
So I live in Boston,
Great.
and I do teach at UIC, and I was trying to understand the Boston data better, and I more understood the excess deaths, and I wasn't sure, where the data was going. Because the one point I was going to make, and maybe you can respond this way, is that Boston and Massachusetts often have low numbers, compared to the rest of the country. A lot of the indicators we look at, but one of the points that we make when we're doing policy and advocacy in Boston is that it was 119 on your chart, but it's still 119. So from the Massachusetts perspective, there's still a lot of work to do. And from the gun death perspective, for example, to compare, is that even though it is the lowest in the country, it's still a whole lot of gun deaths. So, there's still a whole lot of disparity, and structural racism here too, just to make the point that it's not good until it's zero.
Agreed. I so appreciate that point. And it's so interesting. Anytime you start comparing places, these questions that emerge, right? Like, at what point is it a problem? And you're right, it's a problem across the board. But we still think there's value in doing that comparison, and especially that comparison across place and over time. Because otherwise we fall into this trap of thinking of health inequities as monolithic, as deeply entrenched, as universal. And without knowing that variability with far more detail, I think we're really missing out the opportunity to identify local policies that matter, local groups who have made a difference, and that deeper story that Farmer and Dr. Murray and others have always challenged us to try to tell. So thank you for that question.
Thanks.
I see a hand up from Ronald Wells.
Yes, good morning. Thank you so much for the presentation. My question is, really just from your, from your journey, what kind of guidance would you give to health equity researchers, maybe folks in academia or that are currently practicing that, understand the value of data and are really getting these technical skills, but, what have you seen, is really important for us to be able to focus on in these, working with these power imbalances or with, these institutions, just going back to, p-values don't make policy, right? So what are some things that we can focus on as health equity researchers in that regard?
Yeah, great. Thank you so much for that question, because I bet you many others are thinking about it as well. For me, I think it has always come down to making human connections and institutional connections, right? Not just sitting in my office or crunching out data, but taking the time to build relationships, to go visit people. One of the first things that I did early on in my career was reach out to the Ministry of Health in Buenos Aires in Argentina, where I'm from. That's still my home. That's still where my heart lies. And I ended up going there 5 times for month-long stretches to visit, to sit at their office, work on data together, work on papers together. And I wasn't the first author, right? Like it was local people, local colleagues who would take that role. And I remember my colleague Bruno Linetsky at one point said, Fernando, lots of people have asked us for data. Lots of people email us from the United States asking for data. You're the first one who actually came and worked with us and sat at our table with us. And that's when I realized that I was doing the right thing, right? That we were privileging the people and communities and networks and building them, not just myself. And I've tried to do the same thing here in Chicago. When I had research lead from DePaul, I asked Maureen Benjamins and others if I could have a desk to sit at Sinai. And that not only taught me a lot, like you learn from people just sitting with them, but it also brings out a whole different connection to the data by being in different places and different settings. So I guess my advice would be to try to nurture those relationships, both with people and with the institutions that they work in, and know that that takes time, and you always have to bring something of value. So bring something practical. The farmer calls that pragmatic solidarity. Always find something that you can give while you are taking, whether that's just time, whether you help them on a project that they need help with, that they want help with. Find times for those exchanges. So that's not new advice. I bet you've heard that before, but for me, it proved very helpful. Thanks.
Thank you.
Yeah.
I think we have time for one more question.
I see a hand up from Tony Cipriano.
Yes, hi, I'm Tony, and I work at University of Chicago, and I've been there for about 13 years and working in health disparities and cancer. And I'm just curious if you see a place, there's so many of us who don't have PhDs, who are working in these areas and working in this field and working with the communities, but sometimes you're blocked, or there's barriers to going beyond or doing, something more or becoming more involved, because at times you don't really have a voice. So I wonder if there's a place, because there's so many people who want to, make a change and really help in this area, but you feel in academia that you can be blocked at times. So yeah.
No, it's a huge question, and gosh, there's of course no easy answer to that, but it really is the challenge of this has to be a movement, right? This is a movement, and all of us have voices and experiences and capacities to play. One of the things that most, I think, impressed me about SUHI, about the Sandra Brown Health Institute during my fellowship there in 2019, and really in all my connection with them, is how they have valued and incorporated community voices, right? Presenting work not just in academic conferences, but in town halls and churches and other places. Sharing work and interpreting work together with others. Sharing power, even on the level of what questions are asked in surveys. So that kind of community engagement, I think, has always been vital to institutions like Sinai. Not all institutions, of course, but surely is one of the principles underpinning good health equity work. And we're trying to bring a semblance of that to the American Medical Association as well, which historically is not, frankly speaking, a social justice institution, of course, and has harmed, has caused acts of structural violence over its history. It has started the painful process of apologizing for much of that and trying to come to reconciliation with its past. But I think as institutions do this, as institutions issue proclamations against racism, as most of our hospitals and institutions have done in recent years, maybe there's that opening, right, for new and different voices who haven't had that platform before to engage and have space. I'm optimistic that might be the case. Thank you, Tony, for your question.
Thank you.
Yeah.
All right. Thank you, Dr. DeMaio. That was incredibly enlightening and inspiring in terms of the work that really does need to be done. And the variability between cities in terms of the life expectancy gap was truly, it took me aback. Thank you for your time. I know I echo the thoughts of everyone based on the comments that this was an incredibly valuable presentation. Next, we will dive right into our panel of accomplished and well-known women, all of color, from the Chicago area. The panel will delve into how the pandemic has affected the delivery of healthcare and what problems have been uncovered regarding healthcare delivery to minority and underserved communities specifically. So we hope that this panel sparks inspiration for future directions of research that were uncovered during the pandemic. Our moderator for the panel will be Hannah Bonecutter. She was a member of our planning committee and a second-year MPH student here at UIC. So I'll hand it off to her now. Hannah?
Thank you so much, Vishwa. And thank you everyone for being here today. Good morning. I'm so excited to be here at our 2021 annual SPH Minority Health Conference. And again, as Vishwa said, I'm Hannah Bonecutter. I am a second-year Master of Public Health student at the School of Public Health with a division in Health Policy and Administration, a Global Health Concentration, and a Health Disparities Research Certificate. Without further ado, I would love to have all the panelists introduce themselves, to say a bit about some of your work and roles in the public health field. So starting with Miss Angela Ellison, if you could please introduce yourself.
Good morning, Hannah and everyone. Thank you, Dean Giles and the Planning Committee for inviting me to be a part of this conversation. I'm super excited. I know the panelists that I'm on this panel with, and I can't wait to hear what they got to say. My name is Angela Ellison. I am the Senior Director for the UIC Office of Community Engagement and Neighborhood Health Partnerships. I have been that director for the past, 4 years, but have been working for this office for the past 12. I have historically been working around maternal and child health since the mid-'80s, working in the first infant mortality program on the west side of Chicago in the housing developments, where the infant mortality rate at that time was 28 deaths per 1,000 live births. It has not changed much. It has probably dropped about 10 points, but it is still significantly high in African-American communities, I'm sure many of you know. And so I continue that fight and that struggle. I work with community health workers and have been doing that as well since the mid-'80s, because some of those women we hired were considered community health workers during that time. I am also adjunct faculty at South Suburban College, where I teach community health workers in a certification program. And I also sit, thanks to Fernando, as he alluded to, we were in the fight with Representative Flowers to recognize the impact of the maternal mortality rate in the state of Illinois, and how African-American women are 6 times more likely to die than our white counterparts. And as a result of that, I sit as the chair of the state Infant and Maternal Mortality Task Force for African Americans. And I've been doing that since January of last year. So I've been doing a lot of work, and in our office, we have been doing a lot of work around maternal mortality. We have a federally funded Healthy Start initiative that's addressing infant and maternal mortality and has a fatherhood component. So in our office, we've been doing a lot of work around those topics, but also along with the School of Public Health, addressing racial inequities that have certainly been highlighted during this pandemic time. So that's enough about me. I'm sure I'll be talking a little bit more later, so I'll shut up now and wait for the next panelist.
Thank you so much, Ms. Ellison. Next, can Dr. Alejandra Valencia please introduce yourself?
Always I forget to unmute myself. So good morning, everyone. Can you hear me now? Good morning. Thank you so much for the opportunity to be part of this great panel. My name is Alejandra Valencia, and I am currently the director of the Oral Health Forum, which is a program housed in Heartland Alliance Health. Our main purpose is to work to improve access to dental services in the most underserved communities in Chicago, as well as Illinois. And we work this trying to improve or to apply innovative solutions that will address equity and social determinants of health incorporated to the dental access problem that we have. So I am a dentist from Colombia, from Medellin, Colombia. So that's where my strong accent is coming from. And I have the opportunity to work in there clinically for 6 years, serving communities that has a lot of social issues, like, rural communities, communities living in extreme poverty, or communities very affected by violence. And when I came to the United States, I decided to pursue my career in public health. So I am an alumni from the UIC School of Public Health. And then after graduation, I decided to pursue a residency in dental public health. So I am one of for dentists board certified in dental public health in Illinois. I am also a teacher and instructor in the undergrad public health program here at UIC. So I have the privilege to work with Dr. Karen Peters and Dr. Mari Dombo in the global health course that we have at UIC. Thank you.
Thank you so much, Dr. Valencia. Next, would Dr. Cheryl Rucker Whitaker please introduce yourself?
Absolutely. Thank you so much, Hannah. Thanks to the students and the team who put this together, and thanks for inviting me. I am a physician and general internist by training. I did my training at Stanford and the University of California at San Francisco back in the 90s as we were starting to come through the HIV/AIDS epidemic. And I've been here for 23 years in Chicago, working hard on health disparities from multiple vantage points. I'm what you call a radical. I actually took my research background and I broke out. I'll tell you more why as we sort of engage with the panel and the discussion. But I did start out in research as a practicing doc on the South Side in internal medicine. I did a health services research fellowship at Northwestern, where I spent a lot of time with secondary data sets, published a few papers that, unfortunately, the same problems we had then were it's the same ones we have now. And this particular paper was looking at the disparate outcomes in amputation for African Americans versus kind of the data set in total, if you will. And so it was striking and disturbing at the same time. And as you know, an amputation is you're on your way, right? You're disabled by design, and it leads to a number of kind of other challenges that often decrease the mortality, if you will, the living span of those individuals. So I've been involved in disparities fight for a long time. After I left Rush as a faculty member in preventive medicine, where I was funded by the National Institutes of Health and the Robert Wood Johnson Foundation, I left because I felt, wow, I'm studying disparities and I'm seeing it and I'm reporting on it and I'm going to the SGIM meetings and I've got great colleagues and we're all wonderful faculty together, but nothing was changing. I was becoming very frustrated, and this was several years ago. So I went over to the Chicago Community Trust for 2 years. They had a $6 million healthcare portfolio that at the time under Terry Mazzani, the president, I helped kind of revamp some of their thinking and their practices. So I was excited to do kind of some sort of, if you call it global, meaning Chicagoland health planning. But then I crossed over to the dark side into the for-profit arena, because again, I was in the not-for-profit arena. I didn't feel the imperative seemed to be missing, their sense of urgency. So I said, well, let me find out what's going on over here. And I went to work for a health IT company as their chief medical officer. They were publicly traded. Learned an extraordinary amount there about kind of the interoperability of kind of healthcare data and information. Because as a practitioner, I'm wondering, wow, I would see my patients, I would discharge them, of course, to home and community, but I would have no idea if they got their prescription filled, if they saw the specialist they were supposed to see. I would never get a note. I would never get any kind of follow-up on an x-ray. Now, sure, you say, well, you can go and call and find them, but think about that in terms of kind of running an efficient practice. So I never got data easily. I had to track it down, and that could take hours, right? So really kind of started then sort of looking at health information exchange, what was going on at these different points of care, and why did no one seem to care that a person could be seen here, then here, then here, and no one knew what the other was doing, whether that be a physician, a nurse practitioner, or others rendering care. So really started then to sort of try to figure out, if we're spending billions of dollars in Illinois alone, and right now that number is at least 30 billion, if not more, for the state's Medicaid program, with all the different federal matches that are coming in to us because of the Medicaid level rate at which we spend. Why do we still have these intransigent disparities, and why aren't people getting sort of appropriate continuity of care and connection? And so that's when we started Next Level Health Partners, which was the only African-American owned MCO in the country. So I emptied out my savings, started this company, we built it up from scratch. And during that time, we really got to begin to see, we looked at claims data. So we were looking at how the Medicaid dollar was being spent, who was rendering service where and when and to whom, and really begin to see what some of the outcomes were. So I call myself, I love the term Dr. DeMaio used, radical statistics, kind of radical data. That's me. I'm looking radically at how do we shift some of the things that the data is telling us. And as we move forward in this conversation, I'm going to start with the end in mind. I want you all to begin to look at data that we never talk about. We need to look at where the dollars are going, and we need to follow the dollars. Like what are we currently funding, right? And we say funding, I'm not talking about grant funding. I'm talking about Medicaid as a great example. Where are those dollars going, to whom, and what results are we getting? I would love to see you all start looking at that data. So I'll stop there. I'm a radical data statistics person. I took research and I broke out. So I love research. I love data. Ask my kids. I make them give me quantitative reports when they want to make a case for something. They're like, oh, mom. But always you want to look at your data. And so there's some data we're missing. I'm looking forward to talking you guys through some of the places I think we can lean in. Thank you.
Thank you so much, Dr. Rucker-Whitaker. And last but certainly not least, Dr. Vita Henderson, can you please introduce yourself?
Sure. Thank you so much for inviting me here today. Hannah and Vishwa, thank you so much for inviting me to be part of the panel. So I'm currently a research assistant professor at the UIC School of Public Health. I also have the pleasure of serving at the UI Cancer Center, where I'm a senior research scientist and also the director of our Office of Community Engagement and Health Equity. Once upon a time, I was a pharmacist, and I lived in New Orleans during the time of Hurricane Katrina, and my experiences during that time really influenced me to pursue a career in public health. So I left pharmacy, became a broke full-time master's of public health student, and then got my PhD at UIC. So I am really a proud alumnus of our community health sciences program at UIC. Currently, my work focuses on cancer disparities. A lot of my work is with breast cancer disparities. And I guess the common thread among my work is that I really try to increase access and utilization of preventive health services among under-resourced populations. And a lot of my work is, Dr. Whitaker said she's quantitative in nature, I'm qualitative in nature. I love talking to people, hearing their stories, and really understanding what their experiences are and how that can be used in health promotion, health education, and inform the work and the research that we do. Also really passionate about health communication and doing CVPR, community engaged research. So thank you again for having me.
Thank you so much, Dr. Henderson. So I'm going to begin by opening this question to all of our panelists. So feel free to jump in as you are so moved. During the present pandemic, what major trends have you seen in your work regarding healthcare delivery and management, and how have minority and underserved communities been impacted?
Well, Hannah, I'll jump in. And guys, I can talk a lot, so I'm gonna make my answer kind of brief, and then next time I can't go first, okay? Gotta rotate. That's really a lot to unpack, Hannah. That's a very big question. So I'm gonna take just a piece of it and share kind of a couple things. Again, the data on this will be slow to come, but the issues around implicit bias that are in healthcare, okay, that we haven't really unpacked, but there have been lots of great studies that show us that it exists. when I was in residency, there was a paper published out of, it was either UNC or Duke, where they looked at women and heart disease and how women were treated versus men. So we know that bias occurs. That's one example. There's lots of data out there, guys. So imagine putting that on top of the COVID-19 pandemic. And when someone goes into the ER and says, I have these symptoms, depending on where they go and who sees them, they might either be admitted. At that time, it was, you would be intubated quickly. Now they moved to hyperoxygen therapy, right? Aggressive oxygen therapy. Or we had a scarcity of the antibody therapy that came out when the president got it. Was right around the time it was emergency use approved only. Who got that was determined by the system we have in place now, which is a system that houses the disparities. You understand? So there's layers of bias on top of layers of bias. And then you put into play a life-threatening condition, an illness, where you decide that one person's gonna get this and another person isn't. So the same system was in charge of making that decision. So I believe that we won't understand the impact of this for many years to come, because someone has to get around to studying it, because we have to see it. We got to see it in, and the panelists who spoke and said, I'm qualitative. We can get out there and start talking to people, right? And we can probably find out ways that this occurred. And I don't know if we'll even be able to capture it in actual data. But guys, I feel like the implicit bias, which became explicit bias in this situation, was real, did occur, and impacted in ways we won't know. I can't put my finger on it for you, but what I can tell you is that a big time lawyer friend of mine, she had 7 relatives die of COVID-19, okay? One of them, this was, let me say midway through, probably in May of last year, she called the ambulance short of breath, okay? And at that time, that was like the mark of death, right? You're like short of breath, it's gone too far already. The ambulance came to her house on the south side of Chicago and said, no, we're not picking you up, call somebody else. This really happened. Now, in Detroit, they published examples of this happening to a family where several of the male members of that family died of COVID because they went to a hospital and were turned away for care. They said, no, go home and quarantine. They went home and died, or they called an ambulance who said, we're not taking you. So that is an impact that we will not. You're going to say, Cheryl, prove it. Well, you can pull up the Detroit. If you go look deeper, you can find that. I'll disclose my friend's name if she says I can, but trust me, I wouldn't make up a story like this. Her cousin died in part because the ambulance would not pick her up. And that was a time where there was so many, and that was the unfortunate piece about the lies moving around, because it did cloud a lot of people's thinking. But again, not understanding data and how it's used. Let me tell you another way that this has impacted us. When people say minorities are disparately impacted, I think many people, including the President of the United States, he believed, and his people believed, that meant the people dying the most were Black or Latino. No. That's not the case. You understand, more white people died of COVID than Black. But what they're saying is, if Blacks are 12% of the population, they were counted for X percent out of the context of their total in the population. It doesn't mean that the most people were dying. White people died of COVID too. And I think when they started figuring out that they were also dying, we started to get some movement, right? But if you listen to the data, that's why it's so important that you must understand the data, how it's used, how it can be used and misused. But back to implicit bias, let me stay on one point. The system we have now, that structural bias, and I love Doc called it structural violence. Man, I love that. I call implicit bias is structural violence. That's the same system that was administering and many times scarce treatment. Thank you.
I can go next. I can
Yes.
take the question. So I can certainly talk a little bit about how the pandemic has really impacted the delivery system for dental care. And depending on the state, we are talking about nationwide. We have seen, few studies talking about a 35% of reduction in the number of people utilizing or using dental services because of the pandemic. And if we talk specific in the state of Illinois, we have seen that starting for the closing of all dental offices to, to just providing emergency services during almost 4 months. So by the time dental offices start to reopen, like in late July last year, the fear of people for utilizing, the dental offices because of the procedures that we have that can, or that we have to use in some of these dental procedures, which are very, aerosol, producing procedures, people starting, having a lot of fear to come back to the dental offices, but also dental offices were very afraid or forced to put in place a lot of additional procedures to be able to protect their own staff. So the dental delivery system really has been affected. And of course, because of that, the disparities that we saw before the pandemic are getting even more, increasing more because of, we have more limited use of the dental delivery system. So I think the pandemic has also had some good turns in regards to this, because the pandemic has forced especially dentistry to be open to the use of teledentistry because of, either you do it or you cannot do anything. So it forced the system to be open and to catch up with the medical delivery system in regards to, telehealth. And we actually hope that that will be some of the good things that maybe this emergency will bring to the delivery of dental services, that now we will be open to address the dental acts to actually allow the use of teledentistry for now on. And also that the reimbursement system will come in place to be able to reimburse providers for doing these services. So I'm going to stop there to give the opportunity to somebody else.
I would just piggyback off of that. In my work, what we've seen is, at the beginning of the pandemic, there were certain organizations saying, don't go get your cancer screenings, put them off, delay them. And so, when that narrative changed, we just see now it was already hard enough getting people to come in and get their cancer screenings. And now it's even harder with COVID. So, and even in one of my programs where we provide, we navigate patients to breast cancer screening and diagnostic services. Even just in 2020, over half of the people, the women that were navigated through our program, all were delayed from needing follow-up services, where they needed a biopsy. So these are people who need diagnostics. They've already had their abnormal mammogram and they had delayed. And we all know how fast cancers can grow. So this is a trend that we've been seeing, and through the use of patient navigators, we've been trying to, put out that new information out there and trying to get people into clinics so that they can continue their cancer screenings, get in and make sure that they're doing it timely. And I think another thing that, we've seen definitely is this disparity with technology. Not everybody has access to Wi-Fi, home computers, broadband access. And so now if everything's done via telehealth, where does that leave a certain sector of our population? And so that's another thing that, we're really trying to work on. And then lastly, I'll just say, we've seen a surgence of misinformation and disinformation. So really combating when people purposefully put out wrong information out there, and then how do you combat that? How do you change the narrative? And we can see how that impacts use of vaccination hesitancy, in addition to just regular health services that we have. So those are some of the trends that I've seen in my work.
And I guess I'm last. So in my work, I'll start with maternal mortality. And that is what we, as the chair of this task force, we started looking at the information coming in about our communities. We recognize, and a lot of my work is on the South Side. I must admit, I'm a worker bee. I'm used to doing programs and implementing programs and running programs. But when COVID hit, it changed the game. And I think we all know it changed the game. We had to look at things in a different way. And so it opened my eyes. I'm a community person working in academia. So it's really like, okay, now I have to take the best of me and work in academia and pull them both together to change the world. And I'll talk a little bit about that later. But when we looked at maternal mortality, what we realized, and you guys can probably all follow this story, is that on the south side of Chicago, a couple of the major hospitals decided they weren't going to deliver. They closed down their OB units. Now, south side of Chicago is already a maternal desert. You have to travel far, and they did it without informing the community. So here are women showing up at these hospitals expecting to have their baby, to say, you got to travel 20 miles away to go have your baby. That actually happened on the south side of Chicago. The community was informed, wasn't prepared, devastating. So that trend didn't change. Those women still had to try to find how to get to the doctor, coupled with the fact that now we have COVID. So now your partner or your spouse or your loved one can't go in the delivery room with you. So now you don't have any support. In the Healthy Start program, and this is still happening today, none of these factors that started a year ago have changed. And that you can have a lot of support. You may be able, in some hospitals, have one person there, in many places, not any. And so what we see is that there's an insensitivity to the needs of women as we go through this, and it continues. And if you're an African-American woman, it's even worse. So those hospitals that close their doors without consulting community says, your voice don't matter. And we continue to hear we continue to not let people are continually not hearing our voice. I often tell a story about how I am not a statistics, I am a story, because my mother died from pregnancy-related complications when I was 9 years old. She died on Christmas Eve in 1969. And I remember that story. So I'm living this experience and seeing what's happening in our community. So you see the maternity deserts, it's not changing. In our Healthy Start program, just recently, one of my staff stayed on the phone with her participant for 18 hours while she delivered because she had no support system. That's still happening today. So I'm not sure it's happening in other communities, but it's still happening in ours. And so we have to begin to change the system and really look at how we can improve birth outcomes for women and their maternal mortality. Let me also say, one of the things I also share often, if you're in any room with me, is that this is no blame on anyone, but the public health system was not ready for COVID-19. I think we all know that and acknowledge that. It was not ready. However, what we have learned in this time is if we had a workforce, such as community health workers, that we could have tapped, who are people from the community, who can work with the community, who can link people to resources, who can get resources to them, who's not scared to knock on a neighbor's door. If we could have tapped that workforce a year ago, we wouldn't have ended COVID, but we certainly probably would have changed the dynamics of COVID. So I'm gonna stop right now and to wait for the next question. Thank you.
Thank you so much, Ms. Ellison. Each of you have made such amazing and true points, and on where everybody said, I know somebody during this pandemic who has experienced that exact same thing, the narrative that each of you shared. And it is, of course, beyond frustrating for us public health professionals. So this next question, I'm going to tap back to Ms. Ellison. Over the many years of your community work, what have you found to be the most fruitful initiatives and actions taken by community organizations, such as the South Suburban College Community Health Worker Certification Program that you are faculty on, that have improved the health and well-being of low-income, underprivileged individuals in the city of Chicago?
Thank you, Hannah. Now, I guess it won't come as any surprise that I talk about community health workers when I ask that question. I guess it won't come as any surprise, so I'm just going to go with that. For years, as I said, I have been doing maternal mortality and infant mortality and community health work for 4 years. I had the pleasure for 3 years to work a program called Closing the Gap. I worked at the time it was called the Illinois Maternal and Child Health Coalition, is now called EverThrive. The program came about as some funding from HRSA out of their Healthy Start grant. And we ran that program. And the idea behind that program was to train people in the community, to educate the community and link people to resources. Essentially, we were training community health workers. We sent those individuals and we just randomly, we went out to the community, said, who are some good people who are advocates in your community? They identified people. We trained about 20 people in 2 different cohorts. We had about 21 sessions addressing racial equity, addressing low birth weight. The program was addressing low birth weight and prematurity. We trained those 21, it was about 21 people, but we could only hire 4. So we ultimately hired 4, but we kept the other ones and paid them stipends as they did events in the community. We also, as tied to that, we worked with the agencies that were providing these kind of services and provided training for the staff who were doing programs around maternal and child health. So we did case management training and other kinds of training for those case managers who were providing services. So we had a really holistic approach. What was very interesting about that program is when we launched it, we went into the community, we introduced it. The community was involved from the ground up in developing our message and developing the ads that we use, which were very shocking. If you can see them today, usually I show them when I talk about this presentation. The first one had a little bitty casket of a baby in a hearse, and it said, your baby belongs in a crib and not a casket. The public health community was appalled that we would put that out, but the community says you need to shock us, and then you need to educate us. You need to build awareness around this issue. And so we did that. We created the whole curriculum, and the curriculum we used to train and teach with their voices and what they said they wanted to include. So the community was involved. And what was really unique about this program is, guess what? When people think about maternal and child health, they think about moms, but daddies are involved too, significantly. Grandmamas are involved, aunties are involved. So we talked to everybody. We were in liquor stores, barbershops, everywhere we can be. We rode the trains and was educating on the trains. It was so powerful that a homeless man came up to one of my staff and said, I ain't got much, but I'm gonna give you what I have because what you're talking about is important. So that program was so very powerful. The data, unfortunately, the infant mortality at that time had stayed steady for many years. That was 1986 when I started this work. It was 28 deaths per 1,000. When we did this work and Closing the Gap was like 2007. The data did not come out right away. What happened though was that the infant mortality rate had not changed. But 3 years later, when the data finally did come out in the communities we serve, and it was Austin, Inglewood, and Auburn Gresham, in the communities that we serve, the infant mortality rate had dropped by 37%. We take some credit for those efforts because what we did is we changed the paradigm, we changed the message, we changed the way we did things because people have been doing things the very same way. So utilizing people from the community to help the community is something I cannot stress enough. So that is one way I think we can make a change moving forward. Thank you,
Absolutely.
Hannah.
Yes, thank you so much, Ms. Ellison. That is powerful. Please, I have to say, Ms. Ellison, if you have a link to wherever the website or the article or whatever that data that you just shared, please do put it in the chat box for everybody. I know I personally would love to read that. Thank you so much. This next question is for Dr. Valencia. Dr. Valencia, what are some of the main barriers that Latino communities face in accessing and utilizing dental services? How have these barriers changed, whether increased, decreased, or new ones emerged during this pandemic?
Thank you. Got it. Thank you so much. That's a nice question. That's right on my heart. So I love the question. Thank you for that. So some of the barriers that's actually some of the, during my research and my studies, I have truly focused on understanding, how immigrants and specifically Latinos face so many difficulties to access dental care. So some of the major barriers that we have, of course, are related to acculturation many times when we see that, especially if these Latino communities or the Latino immigrants have very short time in the United States, they face a lot of difficulties, right? Being able to navigate the system and being able to access care. Language, of course, become a huge barrier for these communities. Specifically in Chicago, we have had the opportunity to actually look very closely to the barriers that they are facing access dental care. And during the time that we have been serving, communities like Brighton Park, Gage Park, Little Village, we have seen firsthand how, the natural barriers that they face are many times not having dental providers that actually take Medicaid patients is a huge barrier for them to being able to access dental services. Language or being able to communicate. We know that dental brings a lot of fear into many people, not being able to communicate or to being able to express that fear and feel comfortable about, that somebody is communicating about the procedures that they are going to do is very important also. I have seen firsthand, for example, during the last administration, the effects of the immigration, environment against, undocumented immigrants and how that actually affected access to dental services as well as all other services. The way that we saw that is that we saw a huge reduction in those communities in the use of the school-based oral health program, for example, even though all children qualify actually to be seen by one of the providers from the school-based oral health program regarding having insurance or not having insurance, documentation status. We saw during that time a decrease in the use of these school-based dental services because of the fear of the family members, the child, they may have Medicaid, they may be from the United States, but the fact that the parents have to somehow give their names, the information, create a reduction on the way they access dental services. Now, the thing that we have seen now with COVID-19 is that those communities in Chicago where we have been working to address the needs of those population having more dental complaints are matching those communities that are most affected by COVID-19, so we see in play those social determinants of health, how those communities, when we knew by data that have the highest percentage of children with urgent dental needs, exactly match the communities that are facing more COVID-19 cases. So we see in here the importance of addressing those social determinants of health and how they are connected with your whole body, including your mouth.
Wow, yes, absolutely. Dr. Valencia, thank you so much. That was very enlightening.
Thank you.
The next question is for Dr. Rucker Whitaker. What initiatives has Complete Care Management Partners taken during the pandemic that were successful in helping create access to care for the traditionally underserved and increasing the probability of positive health outcomes? And then with that, Dr. Rucker Whitaker, how are you able to stay engaged with patients during lockdown? And how did you go about providing educational information remotely to ensure patients stay compliant and on top of their health?
So Hannah, thank you for that question. So Complete Care is relatively new, starting in December. So I want to talk to you a little bit about our sort of tail end next level health experience, where we kind of transition, but start a completely new company with a little bit of a different focus. So I want to talk to you guys about, goes back to one of the panelists talking about the importance of connecting with community and using talent in the community. So this is not exactly COVID, but it's the type, when someone said the public health system wasn't ready for COVID-19, I wished that I'd had this in place. So I'm going to give you a little bit of what I wish I had. We at Next Level, we had studied our statistics, and we knew that in a community in Inglewood, we were seeing a lot of African-American men not access healthcare, meaning they were covered by Medicaid expansion, which happened with President Obama back in like 2012, something like that. They became eligible. And so they weren't used to having health insurance, right? So they really existed in the shadows, if you will, and they showed up always late. They showed up late stage kidney disease, late stage heart failure with, hypertension as something that wasn't treated, mental health that wasn't completely kind of managed, right? So we connected with a set of barbers in Inglewood and brought them onto our advisory committee, our Complete Health Council. And there's three barbers that we work with. And these guys, these young men were extraordinary. They were very, very smart. Two of them were running their own barber shops. They did community events out of the barber shop. So they would, collect socks and whatnot, food. And when one of them told us a story, when kids come by, they don't have socks. They knew they could come to the barber shop and get a pair of socks. Right. So it was just powerful. And then Next Level transition, and I dropped that. Right. So I want you to know we're going back to pick those guys up and create a council similar to that, so that we're listening to them about what they said about accessing healthcare and getting health information and beginning to shape interventions, guys, that would do that. So we were caught off guard with COVID too. Okay. So we had to move everything remote. So how we stayed in touch with members, Hannah, was really telephonic. It was less than ideal, but it was telephonic, right? We were calling. How are you doing? What's going on? Here's information about what you should do in the home. We sent out masks to members, right? That kind of thing. But to me, that was more parochial. I didn't have feet on the street. So if you ask me, I want you to ask me my biggest failure was, to me, is that we weren't ready for what is already a catastrophic conditions in our community. We weren't ready for that. And I wish I'd had those barbers in place. And like one of the panelists was saying, so that we had a trained group of folks who under any condition can be taught, switch the message, be trained, and then go and start moving. Those guys were probably cutting some heads during that, right? Now in my house, my husband and my son were cutting their own hair. It was kind of hilarious. And we had a lot of fun, like cutting their hair and stuff. But, some folks were getting their haircuts. And so we know these guys were in touch with people because that's their business. It's people. They would have been incredible tools, along with kind of an army of community health workers armed with good information and PPE to distribute PPE, to pass on that CDC related information, and to know where you could go to get good COVID care if you had it. So that's kind of how I think it should have gone. And we put everything together. I'm thinking about the next time, we see something like this, I want to be ready, and having a connection to those local business folks, like those barbers who are young men who often interact with the very people who are most at risk, right? When you don't get good information, you don't access the healthcare system, you go to alternative places to get your information, and then you're late to the dime, right? Which is why it spread so quickly in our community. We didn't get the good information in time. And by the time our medical assistants came home from the nursing home, or people came from working the bus or whatever, they were spreading it all in the community. We did not know, spreading unabated. So we did our role, getting PPE out, telephonic sort of check-ins. But what I wish I had is that sort of barbershop plus community health worker strategy that was ready to go with PPE and good information. Thanks, Hannah.
Yes, thank you so much, Dr. Rucker Whitaker. And I think that barbershop intervention is phenomenal, and likely going off of cultural competency, I wouldn't be surprised if that could also be implemented in other urban cities and metropolitan areas. So thank you so much for sharing that with us, Dr. Rucker Whitaker. This last question is for Dr. Henderson. What were some flaws, gaps, or loopholes you observed in health communication prior to the pandemic? And what ones do you observe now with the pandemic? And what opportunities has the pandemic offered to close these communication gaps?
Yeah, thank you, Hannah. So I think the first thing, I just want to emphasize the importance of health communication strategies and materials, because they really do go far in increasing knowledge and awareness, not only among patients and communities, but also providers and policymakers. And enables us to share the information that we learn from our communities and to, lend credence to their voices and the community's needs. It can also help us influence health behavior and attitudes, and advocate for policy change and increase utilization of preventive services and health services. So I would say prior to the pandemic, again, I think I've already even mentioned the digital divide, what we all have heard of, but I think we take for granted that everybody walking around has a smartphone, but they don't. I mean, 30% of low income families and households don't own a smartphone. And about 44% don't have broadband, don't have Wi-Fi, don't have a traditional home computer. So think about what that means if now we have to move to a world of telehealth, and you have to do your homework and take your tests at home. So, that creates this technology disparity that does impact our health outcomes. And then prior to the pandemic, nothing new. There's language barriers and not having materials that are, in people's languages and that are culturally appropriate and tailored. One thing that I've always looked at is patient-provider communication. Having a trusting and a good relationship with your provider impacts a lot of health behaviors and health outcomes. So when you don't have that, that's something that really impacts people's utilization of preventive health behaviors. And then just general patient education. For example, with breast cancer screening, there's so many different guidelines out there that, it's confusing for patients. And then if your doctor doesn't follow one, then your insurance doesn't pay for it. So, all of those things impact people's abilities to interact with the healthcare system and their health outcomes. And I think currently, with COVID, all of those things are just exacerbated. Again, there's this, learning curve with technology and access to technology. And we've been able to use, Angela talks about community health workers. We use patient navigators, which is a type of community health worker, to really help make those one-on-one connections with our patients and with communities to help facilitate them making those appointments, using their computer, using Zoom, helping with those telehealth appointments, even learning how to use patient portals if you have your EMR system. And then also helping to, like I said, kind of correct that misinformation and disinformation. And you asked about opportunities. I think an opportunity now is there's, I think, more emphasis now on empowering communities and individuals with information in ways that are accessible, easy to understand, easy to read, easy to interact with, and that are culturally relevant. I think there's more of an emphasis. I hear more and more people talking about implicit bias that a lot of our providers exhibit. We know that, a provider just looking at a patient's insurance will often make decisions about that patient's treatment based on what they think that patient can or can't afford. So I think there's more attention to those things that are implicit bias within our healthcare system or structurally violent within our healthcare system, and really mitigating those things. And in my own work, and again, work with Angela, this past year has really enabled me to do more policy work, and which was pretty new to me, but we've seen movement in getting policy that allows for reimbursement of community health workers and patient navigators. Now, for the past few years, we just apply for grants to fund patient navigators. But if we can get Medicaid reimbursement for the work that they do, that would be phenomenal. So we have seen a lot of movement. I think it's sitting on the governor's desk right now, the work that we've done. And then lastly, I'll just end with the importance of broadband access that's, provided by local governments or national governments, so that everybody has access to technology.
Right. Yes. Thank you so much, Dr. Henderson. You brought up so many crucial areas in regards to communication in the health world. So thank you so much. We have about 5 minutes left, and I wish we had more time. This has been a phenomenal conversation and panel. Thank you so much, panelists. But I'm going to just end on a closing question. This again is for all the panelists. So to summarize, what new opportunities for healthcare research have you seen emerge as a result of this pandemic? And perhaps ones that maybe, if we've already discussed, please feel free to just share new ones that you may have noticed that are opportunities for healthcare research as a result of this pandemic. And please also feel free to share any final closing remarks that you may really want us to know and hear. Thank you.
I'll start. I think the most important thing that I've noticed with new opportunities is I'm seeing so many grant announcements that are related to structural racism and that blatantly call out research and projects that really combat structural racism and how it impacts health outcomes. So I think that's super important that that's now in the forefront. And it's not just a result of COVID, but it's also a result of the Black Lives Matter movement. So I think that's really important for us to, jump on those opportunities now that we have it. We don't know how long, those opportunities will last. And I also just want to emphasize, obviously COVID, sign of the times, it's the most pressing issue that we're dealing with now. But I just want to say people still get cancer, they still get Alzheimer's, they still get high blood pressure, so we have to just continue. It's not necessarily about new opportunities, but continuing all of the hard work that we were doing prior to COVID and not, missing that as well. So thanks.
Absolutely. Thank you so much, Dr. Henderson.
I can go next. I think I would love to see, or to take this opportunity to explore new models to deliver dental care, and models that are more based on value-based care, more related to health outcomes, quality improvement, and no, following the current model that we have that is based on fee-for-services, procedures, how many, cavities have you filled, how many things, but more moving into the value base as a way to improve health disparities and promote more prevention in dental care than, procedure-based delivery system.
Yes, absolutely. Thank you so much, Dr. Valencia.
And I will jump in here and say, I may take a little different stance to that question. I will say what I have been, Dr. Giles and others have been inviting me to the table around research, of course, is around understanding COVID, understanding the after effects of COVID, understanding the impact of COVID through a racial equity lens and the systems and how they were impacted. Yes, I'm seeing all of that, but I've got to say this in my closing remarks. As Fernando said earlier, research for research's sake means nothing if it is not impacting the communities that we're doing that research on. If you're just going in your lab or wherever and you're just gathering a whole lot of information and interviewing people and it doesn't come back to the community to change that community, there's no reason to do research. More importantly, we also have to acknowledge research in communities of color is not something that many people say, oh yeah, come on, I'm gonna give you this bio sample so that you can understand me a little bit better. We're not jumping at the line, jumping the line to get some research done on us. So you have to acknowledge the challenges around getting research and educate the community why this is important. You got to understand that when you do research, you got to recognize the norms of those communities when you go out to do research. And it's important that you close the loop when it comes to research. So I have to say that. But more importantly, this is the time to change things. This is the time to change things. And I want to end my part is I was happy to speak today because you are young public health professionals. And in my mind, you're the stop sign. You're the stop sign and you can make changes now so that we can stop seeing the predictions don't come true, that the racial equity gap for women of color and Black people and Black people around communities is growing, that you can change it so it starts to shrinking, so that we can have an equity playing field, so that my children's children are judged by the content of their character and not the color of their skin. You are the change. You can make the difference. That's what this is all about. So I had to end with that. If you're going to do research, do it for the right reasons. Bring your heart and your soul into it. Bring your person into it. Bring your family into it, because it ain't about the numbers. It's about the people. And I'm going to end with that. Thank you very much.
Thank you so much, Ms. Ellison. That was beyond inspiring and extremely powerful. Thank you. And Dr.
Yes, absolutely. Thanks, Hannah. Look, this has been a great panel to be on. I'm so happy to be talking to the future of public health policy, but also I hope practice and literally, like as Angela was saying, making real change. Dr. DeMaio laid a nice path for us. 3,800 excess deaths in Chicago. And that, Doc, that's not in 2020, right? That doesn't show you the COVID excess, right? So, wow, let's do this again next year. He's going to come back with some updated data for 2020, and it's going to stagger us, right? It's going to make us. I have 2 points I want to make. And I agree with Angela about research for research's sake. Now that you all know where we need to go, start researching kind of how we get there. Help us move models forward. And sometimes that's, you got to lean in on policy. Like you said, you had something on the governor's desk, right? So you have to move policy when you find a good way to do things. Let me give you 2 examples of where I believe we have to use research to make an actual difference. Remember I told you about the barbers in Inglewood? Like, I literally love these guys. And they were trying to, one of them's raising his child. He's the main caretaker. Anyway, story you've heard, African-American male, spent time in jail for, guess what? Marijuana, which is now given $1 billion, a week or a month or something in Illinois. It's a huge number, okay? But he was in jail for it, okay? In jail, he got behind on his child support or right when he got out. He wants to get his barber's license back. But the law is in statute right now, says because he's late on his child support, he can't get his barber's license. Structural violence. So how is the young man, he's in late 20s, how is he going to take care of his kid if he can't get his barber's license, which is the craft he was trained to do? Someone needs to undo that violent law against, I'm going to use the name Brandon, against Brandon. Okay, so here's what I'm going to do, because you guys reminded me. I'm going to reconnect with him, and I'm going to figure out how much he owes, and I'm going to pay it. But that's one person. Think about the number of people impacted by laws that are structurally violent. This is violence, guys. And you talk about how to change disparities, that's how you do it. Brandon gets a job where a barber makes good money. He can cut hair, take care of his family, okay? We got to change that. Do some research on that. But actually, there is a report that lists out the laws that are structurally violent against people, particularly those who've been incarcerated or previously incarcerated. And remember, he was incarcerated for marijuana, which is now legal, but he's still suffering those downstream impacts for that very harsh, violent law. We're not talking about fists, but we're talking about economic and social violence against families. Okay, here's my second one. And I swear I'm done, but I thank you all so much for the opportunity. When I was a young doctor in my early 30s, one of my first jobs was covering the ER at Provident. 4 a.m. in the morning, I get a buzz, got to get over there. I think I was there. African-American male, 40-year-old construction worker, seasonal kind of, income, seasonal coverage, hypertension for a long time. Sir, why didn't you take your meds and stay on since you were in your 30s? Well, I couldn't afford it because my cycle on and off, I wasn't on insurance. This was pre-Obamacare, so Medicaid expansion had not occurred. So we ended up with a creatinine of 4, which if you're, that's heading towards renal failure and you're gonna need to be on dialysis. Now, who's heard of Fresenius and DaVita? Those are both kidney dialysis units, right? And if you look on the south side, you drive around, you will see more of those have popped up than any other business probably in our community. Why? Because they do research too. They did the research and they saw the progression of Black people to end-stage renal disease needing dialysis, right? They did it years ago. And they went public. Go look them up on the stock market, look at their market capitalization and how much money those companies make because they did the research. They saw that we were progressing to kidney disease. And they said, well, they're going to need a place to get dialysis. And voila. Why can't bad policy? Why can't we fund prevention and treatment of high blood pressure and diabetes up front that's culturally informed and competent and something that people can agree to? You see what I'm saying? They did the research. And those companies are probably in your portfolio if you have mutual funds. They did the research. You go do the research instead of the solution being let these companies come in and make billions and billions. How about we spend billions on prevention? But you must have data to drive the policy. You have to make a strong case. And then the people who have the money, you force them to make the right decisions. So data is so important for driving good policy, good practice. I need you all as the next generation. Hey, we need help out here. Let's do it. Thank you guys so much. Thank all the other panelists. Love seeing you guys and working with you today.
Thank you so much, Dr. Rucker Whitaker. Absolutely, on all points, especially that data. I am aware of the time. Again, I want to thank all of our panelists so much. I am very hopeful and I think I can safely say very positive that each of us have gained so much from this panel discussion today. Thank you so much again. I hope to see you guys all in whatever public health or other arenas in Chicago and beyond. I'm going to pass it back to Vishal right now to continue our conference. Thank you.
Thank you,
Hannah.
Thank you.
And thank you to all of our panelists. It's been a privilege to hear you guys all talk about this, as well as Dr. DeMaio. I think we've all been inspired. So hopefully we see some positive change come out of all of the students present here today. We're going to take a short break before we head into abstract presentations. So we're going to take a 15-minute break. We'll see you guys back here at 11:10. Before we break, just a couple of things to note. In order for our abstract presentations, we're going to be using a Zoom functionality that has been brought to my attention, is only available in the most updated version of Zoom. So that takes only a couple of minutes. So if you do want to take that upon yourself to make sure that you are using that version, feel free to leave the meeting, do that, and then come back. If not, that's totally fine. Do not feel like you have to do that. We will work around that when we come back. There are other ways that we will make it all work. So either way, it's your decision. We'll be back here at 11:10, and all of the presenters, please stay on the call. Do not leave. We have a little bit to tell you. So everyone else, you can feel free to turn off your video, mute yourself, step away, whatever you choose to do. All right, thank you. abstract presenters, please make your way to the breakout room that you were just assigned to. Everyone else, you're still on the break.